As much as we would like to think that everyone gets a fair shake at the stick in this world, there are real and meaningful inequities that surround us in our everyday lives. And those inequities can become more pronounced as we face increasingly more challenging situations. I'm very excited to talk today with Dr. Maria Hernandez, who is going to take us through a discussion about how healthcare systems can do better at serving vulnerable populations and how women who, believe it or not, are one of those vulnerable populations can better advocate for themselves in the healthcare system. After that, I am going to talk to my good friend, Rachel James, who went out on a limb and decided that for her white suburban family, the place where they really belonged, wanted to establish a business, a home, and contribute to the community is in an underserved, neglected, urban area of the world. I'm going to talk to her about why she did that and why she thinks it is so important that communities be built up and not forgotten. Welcome to the Lindsay Elmore Show, a podcast that helps you find fulfillment amidst chaos. On this show, I interview thought leaders, doctors, creatives, spiritual gurus, and game changers who inspire you to pursue your dreams, overcome obstacles, and leave your mark. Dr. Maria Hernandez is President and Chief Operating Officer of Impact for Health, a California firm that is focused on healthcare innovations that advance health equity. She helps healthcare systems develop strategies, recruit good talent, and develop that talent, engage with their patients and their communities to help overcome healthcare disparities wherever they exist. She also has developed an inclusion scorecard for population health, as well as rubrics and tactics to become a more inclusive leader. Her organization provides healthcare organizations with these proven strategies that help to build a comprehensive, cultural, competent health equity strategy that meets the needs of diverse communities. Dr. Maria Hernandez, thank you so much for coming today to the Lindsay Elmore Show.
Thank you so much, Lindsay. It's my pleasure to be with you.
So we have talked a lot with our guests about racial disparities in access to healthcare. And I think throughout the past year, since the murder of George Floyd and a ton of press for Black Lives Matter, a lot of people are really taking into account racial injustices in health. And I'd like to start our conversation today by saying, that's not the only place where disparities exist. Women face a lot of disparities as well. So let's start our conversation today and talk about the scope of the problem of healthcare discrimination as well as disparities in care.
Yeah, I think that's a really good topic. I always say to folks as we begin these conversations that we've known about health inequities for almost 45 years now. There have been some seminal work that says, people of color, people who don't speak English as a primary language, women, certainly LGBTQ, they all face different types of inequities. And so when we think about women, I think the two things that come up for me as I, do this work, one is on heart disease, and women are less likely to be diagnosed early on when you can do more for heart disease. We misinterpret heart attacks in women quite a bit. We dismiss certain symptoms. And, I think if you look back on the case of, I believe it was Rosie O'Donnell, who had a stroke and didn't know she was having a stroke and didn't get quite the care that she needed immediately and almost lost her life, she became sort of the spokesperson around what women need to think about when considering that they may have heart disease. And if you look again at what women have done in terms of career and work-life changes, most women work now out of the home. Even if you work at home, your life can be stressful, right? And so we know that when women go to the doctor, there is a certain level of bias or a tendency to see what their symptoms may be that don't get analyzed the right way. And so heart disease is an example. The other is another interesting one, knee replacement surgery. You hear a lot about how important that is as people get a little older and their knees are worn out. We assume sometimes that's because of sports injuries. Well, women have quite a bit that they do as well, and they need that too, and yet that's not considered. So those are just two examples, Lindsay, of where I think women face those unfortunate biases that change the kind of quality of care that they get.
So, talk to me a little bit about the compounding of this bias, because the example that you gave to us, Rosie O'Donnell, is on the one hand has some privilege because she is white, but she is a woman. She is also gay. And so if we think about, and I don't know the statistics, how do all of these biases compound? And are there any examples you could give us of like, ooh, here was a situation where the odds were really stacked in someone's disfavor that led to a terrible outcome?
Yeah. So you're really bringing up an important point about those who are at the intersection of race, gender, and other factors. And so there's a really famous case of a young man who was not born male, but actually went through a transition. And because the hospital did not collect the data about his original birth identity, they stopped recommending breast exams and mammograms. And unfortunately, even though this person had gone through a transition and was now a male, they suffered from a horrific case of breast cancer and died. And so there's an example where when a physician doesn't what's called, provide culturally competent care, when you're looking at all of the different factors that a patient may have that bear on their health, you may miss things. And this is one of the reasons why when we think about health equity, it's not about treating everybody the same. It's treating people according to what their needs may be and understanding the unique factors that make for that person's health and their perception of health and their access to the right kind of care. All of those factors need to be in place. So that's probably one of the cases that I've read about the most, which really strikes at the intersection of so many factors coming to bear on making the best decision for a patient.
I know for some of our listeners, the concept of someone being transgender is a lot to take in. And I think that I've had conversations with people and they're like, okay, I understand gay, but I'm just still not there with transgender. I don't understand it. I remember back in college, I took a filmmaking class. It was documentary filmmaking class. And we watched one of the most profound documentaries called Southern Comfort. And in Southern Comfort, there was someone very similar to who you just described, a female to male transgender who did not have the unique care that they needed. He needed very unique care. This led to problems in accessing care where Robert Eads is the man's name, had not gone through a bottom surgery. So wasn't fully there. So still needed care from an OBGYN. OBGYN is like, well, I think it'll make my other patients uncomfortable if you're here. And bless this guy's heart, he ends up dying of ovarian cancer with metastases throughout the entire body. And I think it's so important that these stories get told, because the more that we can empathetically provide care for patients, the better off I know I can do. And I think the more understanding of, we're kind of all just people here in this world doing the very, very best that we can. And the organization that you are chief operating officer for does just that, helping health systems to develop strategies that overcome healthcare disparities. Tell us about the work that you do outside of San Francisco.
Sure. So I think there's two things that we're doing right now that have been just, as you can imagine, Lindsay, we talked about this before the call. They've really ramped up the need to, execute quickly for different hospital systems. One is just training around culturally competent care and training physicians around the impact of unconscious bias. So that training, I think, we just have to do a lot of, and we have to do it really quickly. And we, are faced with a lot of demands of different times where people just are squeezing in this training in the midst of such a chaotic time for all healthcare systems. As you can imagine, everybody's really focused on the response to the pandemic. But I give, the systems that we're working with a lot of credit that they've made this a requirement for their physicians and their clinical teams. And we give examples just like what we've just described in order to help them understand the real application of what unconscious bias means and what it can do in a with patient experiences. The second thing we're doing is we actually spent a couple of years identifying over 75 different best practices that help a system reduce the inequities. And this dashboard we give away for free, but we come in and if needed, we walk people through the process of reviewing these different best practices and helping them determine, what are some of those opportunities for them to adopt these, to implement them, and to support them as they begin to create their health equity playbook. That's what we often encourage them to do as a result of this assessment. And, I'm just delighted that we continue to have so much positive feedback about the work that we're doing, and that by providing this tool, which is online, it gives a lot of the hospitals a way to break down some of the silos that exist in healthcare. Peter Drucker once said, the most complex organization on the planet is a hospital. And I've come to appreciate that that's absolutely true. And so by bringing this tool to a hospital, I think we have the ability to bring a lot of different key leaders together, clinicians together, to identify what they want to do to solve some of those issues.